Hello, my name is Dr.Revathi Raj. I'm a pediatric hematologist and oncologist working at the Apollo Cancer Center in Chennai. We are a premier transplant center, and today I'm here to talk to you about what is bone marrow transplantation. So what used to be called as bone marrow transplantation, we now call it blood and marrow transplantation or hematopoietic stem cell transplantation. A lot of people find this whole concept very complicated, and when children are referred to us for transplant, parents are anxious, they are worried because they think that this is a major surgery or operation. So first of all, let me tell you that this is a medical procedure and there is no surgical part involved. So let me take you through the steps of what is blood and marrow transplantation. So India is a vast country, and we started with about 3 to 4 transplant centers in the late 80s. Now we have close to 100 transplant centers in the country, and every year there are more and more new transplant centers, but experience for treating children with blood disorders and blood cancers, especially in this niche area, is improving every day. So what happens when a child is referred to us for blood and marrow transplantation? The first step is who needs a transplantation. So our blood has 2 components: the cells, which are the red cells, white cells and platelets, and the plasma, which is the white or yellow part of the blood. So if there are problems with the cellular part, which is red cells or white cells or platelets, then we can cure them using a blood and marrow transplantation or BMT. So the common conditions for which we transplant children, one is loss of the entire bone marrow, which is called aplastic anemia or severe aplastic anemia, and red cell disorders like thalassemia major and sickle cell anemia. A lot of you may not be aware, but our country is now the thalassemia capital of the world. There are more than 10,000 new babies born with thalassemia major in our country, and this is very unfortunate, and this is a condition we can prevent with just enough awareness and pre-pregnancy screening and counseling. White cell disorders are many. One is called primary immune deficiency, where the child is born with defective white blood cells. So the conditions such as severe combined immune deficiency, chronic granulomatous disease, so these are white cell disorders for which we offer BMT. Blood cancers are a huge part of the transplant service that we offer. Blood cancers can be acute myeloid leukemia or lymphoblastic leukemia or chronic myeloid leukemia. Majority of the children we try to cure using chemotherapy, but there will be a small group where the cancer has recurred after chemotherapy, which is called relapsed ALL or relapsed AML, or chronic myeloid leukemia CML, which is not responding to chemotherapy tablets like imatinib or dasatinib. So there are also newer indications that we do transplant for. These are called monocytic disorders, and one of them is called HLH, where there is a lot of angry macrophages in the child's body and there is continuous fever, or storage disorders such as mucopolysaccharidosis, Hurler syndrome. So these previously used to be practically incurable diseases, and now we have hope for these children to help cure them using these procedures. So what happens when a child is referred to us for transplant? The principle of transplanting all of these children is the same. There are 7 steps in transplantation. So the first step, we have a patient and we have a donor. So we need a healthy patient. Healthy means a patient who's fit enough to proceed with the transplant and who has the indication to have the transplant. So take for example a child who has a leukemia or a blood cancer. We need for their blood cancer to be in remission. That means as far as we can see, there shouldn't be any leukemia cells left behind in the bone marrow, because the whole transplant process is Also, like gardening, you need healthy soil, you need healthy seeds. So the child's heart, liver, lungs, all organs should be intact during transplantation. So we check that the child is ready for transplant. So okay, we have a patient who's fit and well to proceed with the transplant and for whom it's indicated. Next, we need a healthy donor who can donate these blood stem cells for their brother or sister or their child. So for this, the basis of transplantation is a test called HLA typing. HLA stands for human leukocyte antigen. It is basically a passport which says, this is me, I will accept myself. This is you, I will not accept. So this is our whole immune system in our body which decides what is accepted and what is not accepted. So HLA typing can be done using a blood test, or it can be done by doing just a simple buccal swab, or just testing the cheek cells. So HLA typing we inherit from both our parents. 50% HLA we get from our mother and 50% from our father. So the chance that me and my brother will match completely with the HLA is only about 30%. So what do we do for the other 70% for whom a transplant is indicated? Thankfully, there are a lot of generous people in this world. There are registries within India and abroad whereby more than 30 million people are registered as a stem cell donor. And we can put in the HLA typing of the patient, see where in the world there is a fully matched donor. So we have identified the patient, we have identified the donor. The next step is to admit the patient and give them high doses of chemotherapy or radiotherapy so that all their blood stem cells will dissolve and come out in the urine. So this part is called conditioning. Normally conditioning lasts for about 1 week. So in this 1 week, the child goes through difficult time because we need to use pretty heavy doses of chemotherapy or radiotherapy in order to eliminate their bone marrow stem cells. Only if their stem cells are eliminated and if their immune system is low can they accept new stem cells. So we use drugs like triosulfan, busulfan, fludarabine or whole body radiotherapy, and huge amounts of advances have happened in this field also. So we're able to support the children quite well right from newborn period to anyone close to 65 years. And once this 1 week is over, their blood cells come down to 0. So on the 8th day, we take the stem cells from the donor and infuse it into the child. So it's a very simple procedure. Most parents are surprised that the transplant is only like a blood transfusion done by our unit nurses. The donor on the day of donation can donate the stem cells in 2 different ways. So our bone marrow cells can be harvested in the operation theatre. The donor is given full general anesthesia, and from the hip bone we can take small amounts of blood and this can be used as stem cell donation. So we count the number of stem cells using a test called CD34. We need at least 5 million cells per kg body weight of the patient. The other advance in this field is peripheral blood stem cell donation. It's a simple outpatient office procedure where the donor has 4 days injections. Some of their blood stem cells come into the peripheral blood, and the bone marrow cells are in the peripheral blood, and we have technology whereby we can collect these cells like a blood donation. And these cells are then infused into the patient. They go into the patient and settle into the bone marrow spaces and start making new blood only after 2 weeks. So these 2 weeks we have to look after a child who practically has 0 blood, who's received high doses of chemotherapy or radiotherapy. So there's bound to be mouth ulcers, vomiting, loose stools. So we need to provide actual proper supportive care. We need infection control team and a whole load of nursing team. and without teamwork we cannot get through this whole procedure. So it's not a one-man show, and we need trained nursing, pediatric ICU staff, blood bank, microbiology, housekeeping. A lot of effort is involved in getting through the 2 weeks. After 2 weeks, the blood cells start to improve, and then we test the blood, and it's a beautiful situation where all the blood cells are now belonging to that of the donor. So that is called chimerism, donor chimerism. We want it to be 100% donor. So then the child is then ready for discharge. So the total hospitalization is anywhere between 3 to 4 weeks. Now we have a new person's blood in our body. How are we going to deal with them? So there are new stem cells in the child's body. So the child should not reject these stem cells, or the new stem cells should not reject the child. When the new stem cells reject the child, that's called graft versus host disease, which can result in uncontrolled diarrhea, skin rash, or liver problems. So we keep the immune system down by giving medications like cyclosporin and tacrolimus for anywhere between 6 months to 1 year. In 6 months to 1 year, both the new stem cells and the body accept each other. Then the child is given all their vaccines that they received as a baby, and then their immune system is back to normal and they can lead a life like anyone else. What is life after bone marrow transplant? So if all stages go well, step by step, the children do really well. So some of our post-transplant kids are now doctors, engineers, and leading a full life. So life after transplant can be really optimal, and that is what we aim to give for every individual child when we start the transplant. So, but they do need follow-up. They need their vaccinations, they need to check their height and weight and growth and puberty, and also all the hormonal assays, and for the heart and liver function. So this is all called long-term follow-up, because we've used heavy doses of chemotherapy in a growing child. Fully matched sibling or an unrelated donor, we are now using haploidentical or half-matched transplant. And in this technology, we use a half-matched parent or a brother or sister to do the transplant, and this advance has made a huge difference to offering a cure to patients in my own lifetime. The other aspect is long-term follow-up. Especially with hormone and endocrine, they will need multidisciplinary follow-up. So transplantation, the way I look at it, will be the hope for a lot of our children. In future, maybe we will have gene therapy in our country, which is also a form of transplant. We're going to use missing genes to be sent into the child's body, but they will have to go through the same process of transplant with their own stem cells. So hopefully we'll have more of these children coming to us, and rather than have a lifetime of suffering, they're able to get one-off chance of cure to lead a normal, healthy life. Thank you.